ದೇರಳಕಟ್ಟೆ ನಿಟ್ಟೆ ಪರಿಗಣಿತ ವಿಶ್ವವಿದ್ಯಾನಿಲಯ ಕ್ಷೇಮ ಮೆಡಿಕಲ್ ಅಕಾಡೆಮಿಯ ಸೆಂಟರ್ ಫಾರ್ ಅಡ್ವಾನ್ಸ್ ಡಾಕ್ಟರ್ ನ್ಯೂರಾಲಜಿಕಲ್ ರಿಸರ್ಚ್ ಸೈನ್ಸಸ್ ವತಿಯಿಂದ ಬಹು ಅಂಗಾಂಗ ಗಟ್ಟಿಗೊಳಿಸುವಿಕೆ ರೋಗಗಳು ಹಾಗೂ ಭವಿಷ್ಯದ ಸವಾಲುಗಳು ಕುರಿತಾದ ಕಾರ್ಯಾಗಾರ ಕೆಎಸ್ ಹೆಗ್ಡೆ ಆಸ್ಪತ್ರೆಯ ಚಿಂತನ ಸಭಾಂಗಣದಲ್ಲಿ ಗುರುವಾರ ನಡೆಯಿತು. ಕಾರ್ಯಕ್ರಮದಲ್ಲಿ ಸಂಪನ್ಮೂಲ ವ್ಯಕ್ತಿಯಾಗಿ ಭಾಗವಹಿಸಿ ಮಾತನಾಡಿದ ಯುನೈಟೆಡ್ ಕಿಂಗ್ಡಮ್ ವೆಲ್ಸ್ನ ಕಾರ್ಡಿಫ್ ವಿಶ್ವವಿದ್ಯಾನಿಲಯದ ನ್ಯೂರಾಲಜಿ ವಿಭಾಗದ ಪ್ರೊಫೆಸರ್ ನೀಲ್ ರಾಬರ್ಟ್ಸನ್ ಅವರು ಬಹು ಅಂಗಾಂಗ ವೈಫಲ್ಯವು ದೃಷ್ಟಿಹೀನತೆ, ನೋವು, ಕೈಕಾಲುಗಳ ದೌರ್ಬಲ್ಯ, ಆಯಾಸ ಸೇರಿದಂತೆ ವಿವಿಧ ರೋಗ ಲಕ್ಷಣಗಳನ್ನು ಉಂಟು ಮಾಡುತ್ತದೆ ಎಂದು ಹೇಳಿದರು. ವೆಲ್ಸ್ನ ಕುರಿತಾಗಿ ಪ್ರಾತ್ಯಕ್ಷಿಕತೆ ನೀಡಿದ ಇವರು ಪ್ರಪಂಚದ ನಾನಾ ಭಾಗದಲ್ಲಿ ವಿವಿಧ ಕಾರಣದಿಂದ ಈ ರೋಗಕ್ಕೆ ಪ್ರತಿ 5 ನಿಮಿಷಕ್ಕೆ ಒಬ್ಬ ಚಿಕಿತ್ಸೆಗೆ ಒಳಗಾಗ್ತಿದ್ದಾನೆ. ರೋಗ ಲಕ್ಷಣಗಳು, ತೀವ್ರತೆ ಮತ್ತು ರೋಗಬಾಧೆಯ ಅವಧಿ ವ್ಯಕ್ತಿಯಿಂದ ವ್ಯಕ್ತಿಗೆ ಬದಲಾಗಬಹುದು. ಕೆಲವರು ತೀವ್ರವಾದ ದೀರ್ಘಕಾಲದ ರೋಗ ಲಕ್ಷಣಗಳನ್ನ ಹೊಂದಿರಬಹುದು. ಅದು ವಾಸಿಯಾಗುವಂತೆ ಮುನ್ನೆಚ್ಚರಿಕೆ ವಹಿಸಬೇಕಾಗಿದೆ ಎಂದು ಹೇಳಿದರು. ಇನ್ನು ಕ್ಷೇಮ ಡೀನ್ ಪ್ರೊಫೆಸರ್ ಪಿಎಸ್ ಪ್ರಕಾಶ್ ಕಾರ್ಯಕ್ರಮದ ಅಧ್ಯಕ್ಷತೆಯನ್ನ ವಹಿಸಿದ್ರು. ಕಾರ್ಯಕ್ರಮದಲ್ಲಿ ಕ್ಲೇರಾ ರಾಬರ್ಟ್ಸನ್ ಉಪಸ್ಥಿತರಿದ್ದರು. ಕ್ಷೇಮ ಸೆಂಟರ್ ಫಾರ್ ಅಡ್ವಾನ್ಸ್ಡ್ ನ್ಯೂರಾಲಜಿಕಲ್ ಸೈನ್ಸಸ್ ನಿರ್ದೇಶಕಿ ಡಾಕ್ಟರ್ ಲೇಖಾ ಪಂಡಿತ್ ಸ್ವಾಗತಿಸಿದ್ರು. ಪ್ರೊಫೆಸರ್ ಹರ್ಷ ಹಾಲಹಳ್ಳಿ ಪ್ರಾಸ್ತಾವಿಕ ಮಾತುಗಳನ್ನಾಡಿದ್ರು. ಡಾಕ್ಟರ್ ಸುಮನ್ ಕಾರ್ಯಕ್ರಮವನ್ನ ನಿರೂಪಿಸಿದ್ರು.
Credibility to a disease that nobody understood among the medical community or in the lay public, for which treatments were not available, and the trials and tribulations of working as a neurologist treating diseases which were less frequent than the common colds, coughs, seizures, epilepsy, and so on. So I just wanted to give you what we have done using the example of our registry, which is got a very nice acronym, MANDIR, and this is our story. So you may ask, why tell us your sad story? We don't really need to know about it, but surely you need to, because there is a global increase in prevalence of autoimmune disorders worldwide. Even in countries where the prevalence has been studied meticulously, there is definitely over the decades a genuine increase. And it's not just because we have more MRIs and more neurologists in our part of the world. There has to be a genuine increase in the numbers of patients that we see, and that is also reflected in the number of patients I see in my practice. And also you should understand there's a significant skew in the ratio between women and men affected.
To say that it's not an uncommon disease, though we can't call it as uncommon, not an uncommon disease. And possibly we should be looking out for these, particularly the ophthalmologists, the pediatricians, and the physicians. Look out for look out for the signs and possibly early referral, and using the services of our neurological department. Interventions can possibly, as Professor Robertson said, an early intervention during the meso period can have a better outcome. Otherwise, as all of us know, demyelinating disease itself is a very heterogeneous group of disease where multiple sclerosis is quite common. And the thing about this disease is exacerbations, remissions, and every exacerbation leaves its mark. Ultimately, it may not kill an individual immediately, but cripples. And over a period of time, not only the patient suffers because of the quality of life, the caregivers also gets affected. So we definitely, and look at the population difference. Young, very productive age group, and also the young caregivers. So we need to look. Right now, we have early therapeutic interventions designed. Of course, it should be much more cost effective. We need to have possibly biomarkers, early detection biomarkers, markers for exacerbations, early detection of exacerbations, so that we can keep the disease under remissions, have a few exacerbations, thereby decrease the incidence of disease, sorry, not the incidence, the going into crippling stage. Of course, the treatment or the management of multiple sclerosis is a multimodality specialty wherein ophthalmologists, neurologists, physiotherapy departments, all these get in, and also the counselors. Because whenever a disease has this is a type of manifestation. Along patience is required on the part of the patient, the caregivers also.
Diseases of one type or another, we'll see probably twice that number to tell them they don't have that, but we make around 100 to 150 diagnoses a year. So we have a 97% case capture, so it's population based. So again, slightly different, because people don't come from long distances to see us, generally apart from second opinions, but we know all the patients who have MS and related disease in our catchment area for around 1.5 million. And we follow them all up, so we perform an annual assessment, which clinical assessment on them. That means that there are about 60,000 assessments in our kind of data bank looking at those individuals. And we keep them in this customized database system called patient care. And again, we have a parallel biobank. You can see it's very mirrored, this system, with about 120,000 samples of them. And we're interested, as you hear, in long-term outcomes and biomarkers. And our aim really was to develop this lifelong library of clinical information from disease onset to death. And so we collect patient-reported outcome, clinician-derived data. We have this rather bizarre scale in multiple sclerosis called EDSS, which is a bit difficult, lots of problems, but it is something that's embedded in our culture in MS. But also digitized MR scanning, genomics, so I think about 2,000 of our patients have whole genome screening data, all the demographics, which is linked to a national system, which is updated in real time, and the biological samples, which I'll talk about. So again, this is slightly different. So our registry covers in total about 3.2 million, but is much more focused in the south and east. And we have about 4,500 patients in our registry. But only a small number of them will be NMO, by which I mean Morgado Act 4 and 4. But the vast majority will have multiple sclerosis. And you can see that we have a kind of normal split in terms of multiple sclerosis, with just less than half of relapsing disease and secondary progressive disease, and then about 11% of primary progressive disease, and a few percent of clinically isolated syndromes, which are becoming less and less as the diagnostic criteria are changing. We're able to make diagnosis much earlier based on sequential scans and lumbar puncture results. And over the years, as we've monitored